Okay, so we're going to talk about syphilis point of care testing. I have about 45 minutes. I can get through my slides in about 35 minutes, depending on how fast we're talking and how fast y'all are giving me those emojis and reactions. And then we'll have time for questions at the end. But if you have a burning question and you do not want me to move on, raise your hand and I will stop and answer your question. So, like Lauren said in her very nice and brief introduction, which I appreciate, I work for the Denver Prevention Training Center. There are 8 regional prevention training centers across the country, and y'all, Denver is the states assigned to Denver and in the green, and that's where y'all are at. That's why I'm here today. I hope you all know about the STI mobile app. It's basically the treatment guidelines from the CDC in app form, so you can very quickly look at stuff, and it's very useful, so I hope you use it. I hope you all also know about the STD-CCN, which is a clinical consultation network. If you have a question about how to implement something, a question specifically about a patient, protocols, if you want copies of protocols, from our Denver Sexual Health Clinic, this is the place to go. And we can usually respond between 1 and 5 business days. So here are our objectives for today. We're going to talk about different syphilis screening strategies. We're going to talk about the difference between point of care and lab-based syphilis testing. We're going to talk about why point of care testing might be useful in patient care, and then identify some target populations, some tools, and some protocols that will help in implementation. Okay, our first poll is coming up. This one, you're going to use the chat. Where are y'all with point of care testing of syphilis? Are you using it at your site or your hospital? Anywhere in your hospital, in your department? If the answer is yes, go ahead and type A in the chat. If it's no, but you want to implement in the next 3 to 6 months, type B in the chat. If it's no, and you have no plans to use it, type C in the chat. If you're not sure, D. If it's complicated, E. Okay, I see the chat numbers that are going up. So I think people are, I see some A's, a couple of D's. Okay. It's complicated. Ooh. Thomasine is starting next month. Okay. So good mix of folks. So let's start with why we're even talking about point of care testing. I'm sure you all know, and I don't need to tell you this, but really to reiterate that syphilis rates have been going up since 2019. We've seen an overall increase, 61% increase in syphilis cases since 2019. And for congenital syphilis, we've seen a 106% increase since 2019. So rapid point of care tests are a strategy, a way to quickly identify syphilis cases and hopefully provide timely treatment when we use those rapid point of care tests. And it's also important that we're focusing our syphilis efforts on the populations that are disproportionately at risk, and that includes pregnant people. And again, something this group probably knows pretty well is that congenital syphilis is totally preventable. This is, I'm sure you've seen this slide in different places. This is from a review that CDC did in 2022, looking at all of congenital syphilis cases in the US. And they determined that 90% of the cases could have been prevented with if there was timely testing and timely and adequate treatment provided. And then they also found that in 2 in 5 cases of babies born with congenital syphilis, the pregnant person did not receive prenatal care. And so if we could improve timely testing and then provide adequate treatment, that would help prevent a lot of these cases. And so that's why point of care testing has really entered the conversation as a strategy to help with that, because in certain situations, this can really help you identify cases quicker, and then in some cases provide an opportunity for same-day treatment. So this is one of the reasons why we're talking about it. Now, we're going to discuss the pros and the cons of point of care testing in a little bit. Will point of care testing solve all our congenital syphilis problems? No, but it's a really useful tool to have in the toolbox, and so that is why we are talking about it today and in general. Okay, so in terms of Screening strategies. The CDC has outlined some key strategies to improve syphilis testing and treatment, and we'll go over that together. But to be clear, this is a both and strategy, not an either or. So first is what I'm calling universal screening in high prevalence settings. CDC is calling this geographic screening. So from an implementation standpoint, this makes sense to my brain, which is why I'm using this language. And I'm hoping that it also makes sense in the implementation setting. Essentially, what this sort of universal approach means is that if you're in a high prevalence setting, and that could be based on your county or it could be based on your location, ED, STI clinic, LND, OB triage, depending on what your syphilis rates are. If people who are sexually active and age 15 to 44 come into that high prevalence screening, high prevalence setting, you're going to screen everybody. You're not going to ask them a bunch of questions. You're just going to say, we're in a high prevalence setting and you are 15 to 44, you get a syphilis test. This is what we do for everybody. So that's why I call that the universal approach. And then the other approach, which again, remember, this is a both and, because not everybody is going to fit into that high prevalence and 15 to 44 category. So if in those cases, you're still going to continue your risk-based screening, and that risk-based strategy is what we're used to most of the time, which is we're screening asymptomatic adults who we know are at increased risk, and we'll talk about increased risk shortly. We're testing folks who present with signs and symptoms of syphilis, and then if we know that folks have been exposed to syphilis through a partner, we're going to test those people as well. So that's your risk-based strategy versus your universal screening strategy. And you can choose this from an implementation standpoint. So in the emergency department at Denver Health, we really wanted them to go with the universal screening strategy and to screen everybody who came in, but we're not a high prevalence setting. And also that's a lot of syphilis tests for an ER to run. And so in our conversations with them, we sort of moved to this screen all people who are pregnant and not in prenatal care. And then you want to do risk-based for these people. And so you can sort of decide based on your setting and resources available, which of these would be your first step approach, and then which is your secondary, because again, this is a both and situation, not an either or. So in terms of risk-based screening, who are the populations that we have clear and defined recommendations for? And that's a pretty long list. So pregnant women, we know that they should be screened at the first prenatal care visit. And I would add here, if you're a place that does pregnancy testing, that positive pregnancy test is an opportunity to do a syphilis test at that point and pair them. As we know, some folks who end up with babies with congenital syphilis don't engage in prenatal care. You don't know who those folks are going to be typically when you do that positive pregnancy test. So that's an opportunity to do a syphilis test anytime you have a positive pregnancy test. And then later on in pregnancy, to make sure we're screening early in third trimester. Usually folks do it at 28 weeks because folks are because the patients are coming in for other testing at that time, and then again at delivery. For men who have sex with men, transgender and gender diverse people, the recommendation is at least once a year, and then you repeat every 3 to 6 months based on risk, whether they're on HIV PrEP or DoxyPEP. For people who are on HIV PrEP or DoxyPEP, the recommendation is to screen for syphilis when you start either of those medications and then continue every 3 to 6 months. And then for people living with HIV, you're going to screen for syphilis at their first visit and then at least annually. And if they're at increased risk, you'll do it every 3 to 6 months. For populations where there aren't like defined time periods for when syphilis testing should be done, it's men who have sex with women and non-pregnant women. But we know this is important. These are important populations to screen. And so the recommendation here is to just screen these folks based on increased risk. And this is what increased risk means. It's a long list of factors. The good news is that if you're doing a pretty detailed sexual history, all these factors are going to come up. From an implementation standpoint, you could literally build a questionnaire based on this and have checkboxes that are you a man? and younger than 25? Are you currently incarcerated? Hopefully you would know that. Or do you have a sex partner who was recently incarcerated? Are you engaging in survival sex? Meaning exchanging exchanging sex for something that you need. Are you using illicit drugs, especially meth, with sex? Are you experiencing homelessness or have unstable housing? There's individuals a history of military service. That's pretty important if you're in a population where there's a military base nearby or pretty big population of military folks working in the area. The other question is about concurrent partners, people with a previous history of syphilis infection, people who've been diagnosed with any STI in the last 12 months, and then people who are having condyless sex. So again, all of these will come up if you're taking a detailed sexual history. And if you need to include this in a protocol, you can include it to say for standing orders or delegated orders that if people meet any of these criteria, they would get a syphilis test. So that's one way to think about it from an implementation standpoint. Pretty great for a questionnaire, or you could do your traditional sexual history as well. Okay, we're going to talk about syphilis serologic testing. To figure out how much time I need to spend here, I'm going to ask you a few questions about syphilis serologic testing. So let's get ready with those emojis. Again, thumbs up means this is true. Thumbs down mean this is not true. And big eyes emoji if you're not sure. And then if it's complicated, just put a random emoji. So this one, which of the following statements is true about syphilis serologic testing? So, is it true that to diagnose syphilis, you need both a treponemal test and a non-treponemal test? And I've given you examples of a treponemal test, that's a TPPA or an EIA, and non-treponemal RPR. So is it true that to diagnose syphilis, you need to get both of these types of tests? Give me a thumbs up if you think that's true. Question, the problem is I can't see the reactions. Lauren, please help me.
I'm not seeing any yet either.
Okay, so I'll go through all the other options, but we'll revisit. So is it true, the option B, is it true that to diagnose syphilis, you only need one of these tests? You can get either one, and that will give you the answer. So to diagnose syphilis, you'd either need one treponemal test or one non-treponemal test. Is that true? Thumbs up or thumbs down. C, is it true that point of care tests are not useful in diagnosing syphilis? I will tell you that that is not true. Otherwise, we would not be here this morning. And then D, is a PCR swab of a chancre the best way to diagnose syphilis? So let's go through. Is A true? To diagnose syphilis, you need both a treponemal and a non-treponemal test. Thumbs up if you think that's true. Okay, Tina said she's seen reactions.
I do see a couple of A's in the chat, and I did see a thumbs up to that question.
Awesome. That is the answer. To diagnose syphilis, you need both a treponemal and a non-treponemal test. In most cases, you need both of those to diagnose syphilis, screening and a confirmatory. So B is wrong for that reason. I already told you that C is wrong. And then D is wrong because we don't do PCR swabs of chancres for syphilis testing, where we just don't have that technology quite yet. That's disseminated everywhere. Okay, true or false? This one's less complicated. To diagnose syphilis, it does not matter which test you order first. So you could start with either a treponemal test or a non-treponemal test. Is that true? Thumbs up if you think that's true. Thumbs down if you think that's false. Big eye emoji if you're not sure. It's complicated. Just give me any random emoji of your choice. Okay.
See a couple of thumbs up again, and then A's in the chat.
Okay. Oh, I figured out a way to see all the reactions. Okay, great. Late in the game. Last question. All point of care tests that are currently available in the US are treponemal tests. If you think that is true, thumbs up. If you think that is false, thumbs down. If you don't know, give me those big eye emojis. If it's complicated, give me some random emoji of choice. Let me see some crying cats, some dancing twins, some dancing sangria lady in the red dress. I don't know why I call her sangria lady. That's not the right word I'm looking for. What's the dance that you do with the castanets? Anybody? Okay. I'm going to stop demonstrating my castanets. Linda, thank you for that emoji. That's my second favorite emoji that I use all the time. Okay, so let's talk about it. So generally for a serologic test, you're either getting a non-treponemal or a treponemal test. The two things that these tests have in common is that they are both antibody tests. They're looking for antibodies to something. And then the other thing that they have in common is that it doesn't matter which test you start with. You can start with a non-treponemal, you can start with a treponemal. But what is true most of the time is that you always need a confirmatory test to know if this is syphilis or not. So those are the two things that the tests have in common. Both antibody tests, doesn't matter which one you start with. So let's start with the non-treponemal tests, which are also called lipoidal antigen tests. This is new language that CDC is trying to socialize. So the non-treponemal test, again, it's an antibody test, but it's looking for antibodies to a non-specific antigen. And these are lipoidal antigens. And these antigens get released anytime there's cell damage or a cell dies. So that could be a cell being damaged by an infection. That could be the immune system damaging and killing off cells to kind of clean up some cells. And so you will see a positive non-treponemal test when there's immune system activity. The other thing that this test does, it's a yes and test. So it will tell you, yes, this test is positive, and then I'm going to give you a number, usually a titer. It's like 1 to 2, 1 to 256, 1 to whatever. And that reflects the activity of disease. And when I say activity of disease, that's like either the infection killing off cells or the immune system triggered by the infection, and the immune system is also trying to kill off the bacteria or whatever that is causing the infection. So I get this question a lot. The titer is 1 to 256, so that means this must be primary syphilis, right? That is not true. The titer doesn't tell you the stage of syphilis, it just tells you the immune system is doing a lot of stuff. If the titer is 1 to 2, there's a tiny little rumble. If the titer is 1 to 1,206, there's a big rumble happening. The immune system is cleaning stuff up, and there are lots of cells dying. That's really all that titer tells you. So non-treponemal, non-specific antibody test tells you activity of disease. Then the other flavor of test, the treponemal test, this is detecting specific antibodies to T. pallidum, which is the bacteria that causes syphilis. So this is, if this test is positive, it tells you this person has antibodies to T. pallidum, meaning that this person recognizes this bacteria. This person's immune system recognizes this bacteria, either because T. pallidum is there now, or T. pallidum has been there in the past and the immune system remembers. And so the one thing about this test is that it only helps you the first time a person has syphilis, because once it's positive, it, for the most part, will always be positive. So that's why it helps you. So it helps you the first time, it doesn't help you again. So that's why I say most of the time you need both tests, but if a person has had a previous syphilis history, you will still get both tests because that's how the algorithms go. But one of them is really going to help you, and that's going to be the RPR. And the treponemal test will just confirm that this person has had syphilis before. And then examples of treponemal tests are TVPA, EIA, CIA, the FTA some people use, but CDC is really encouraging people to move away from that. And then syphilis IgG is another one. And then all point of care tests that are currently approved for use in the US are treponemal tests. Okay, so moving on to the algorithms. You can see here the orange highlighted bar is the traditional algorithm, and then the blue highlighted is the reverse sequence algorithm. It doesn't matter which test you start with. The traditional algorithm starts with the RPR or VDRL, and the reverse sequence starts with the EIA or CIA or some other treponemal tests like the TPPA. Again, doesn't matter which one you start with. What usually determines which algorithm folks are using is cost, laboratory expertise, and availability of machines to run the test. So the CIA and EIA and some of the other treponemal tests can be run in batches in machines. So lots of hospitals will do the reverse sequence because they can run a bunch of patient labs at once. And it tends to be cheaper that way. So lots of folks use that algorithm. Either one is perfectly fine. You just need to follow all the steps and make sure if one test is positive, you're getting the reflex test as a second one. And I mentioned reflex testing because this is another sticking point for syphilis screening in populations, is some lab protocols don't automatically do the next test if the first test is positive. They will wait for you to put in an order or something, and that causes lots of delays. So if you're in an institution that's doing syphilis screening, make sure that your lab has a protocol to reflex to the next test if it's positive, so that you don't have to pause, find the patient, and come back, and that causes a lot of delay. So that's one way that we can decrease the time of diagnosis of syphilis. In terms of how good the tests are, in general, most of the tests have lower sensitivity, meaning they're less likely to pick up an infection in primary syphilis. And that's just because it takes a little time, because these are all antibody tests. It takes time to have that antibody develop. And so it could be like 3 weeks after an infection to see a positive result. So if a person presents with a chancre or what's clearly a sign of primary syphilis, and your test is negative, please treat that person. If you think they're going to come back, you could wait 1 to 2 weeks and repeat your test, and for sure it will be positive by then. And so in general, tests have a lower sensitivity in primary syphilis, but you can see the treponemal tests are still pretty good, better than the non-treponemal tests. And then in secondary syphilis, when a person might show up with a rash, the immune system is pretty awake in secondary syphilis because it's like, something's going on, I need to figure this out. And so all of those tests will pick up secondary syphilis very well. And then for latent syphilis, your non-treponemal test sensitivity, their likelihood of picking up infection goes down just a smidge. But again, all the tests are pretty good. In terms of point of care testing, you can see that overall, the point of care test has a lower specificity and sensitivity, not by much, but just a little bit. And really what that means is that you might have some false positives and some false negatives in the when you're using a syphilis point of care test. So false positive meaning the test is positive, but this person doesn't have active disease. That could happen if this is a person with a previous history of syphilis, but we did the test because we didn't know or they didn't remember. It could also just be a biologic false positive. The test is positive, they don't have syphilis at all. So that is more common to see false positives. When we did this evaluation of the positive syphilis test in our outreach setting, it was more common that we saw false positives. It was very few false negative results. So meaning that the test was negative, but the person had syphilis. So I say that to say, the point of care testing is the beginning of understanding whether a person has syphilis. It is not the end. You'll still need your confirmatory test. You'll need clinical evaluation, get a detailed HPI, ask about some review systems, do an exam, and then use all that information to determine whether or not a person has syphilis. Okay, so we're going to talk about the 3 point of care tests that are currently available and one that is maybe going to be available in the future. So the first one is Syphilis Health Check. It's been around the longest. This is what I, not to be self-referential and cite my own paper here, but this is a paper that was my first thing I did as a resident and my capstone project for my master's in public health. And essentially, this is a great test that's available. It's fairly cheap, about $10 to $20, which depending on your supplier. It has an okay reimbursement rate. I think these are Medicare rates. And it kind of works similar to a pregnancy test. But you're using finger stick whole blood instead of pee. But if there's 2 lines, it means it's positive. If there's 1 line, it means it's negative. So it's fairly easy to do, just a finger stick, put the blood in the little well, wait 10 minutes, and it sort of wicks across this paper. And so it works pretty well. Anybody can do it with some training. One thing that we'll say we had challenges with is sometimes there's like a ghost line where you're like, is this a clear positive? Is this a false positive? Is this a faint line? I can't tell. So having in a place with really good lighting, and then the more that folks do them, the more they get comfortable. You'll probably have some overcalls in the beginning, and that's fine. But pretty easy test to use, a little bit tricky interpretation in some cases, but great option. So so those are the advantages of the test. Some disadvantages is that you can't distinguish between old and new syphilis because it's a treponema test. Once it's positive, it's always going to be positive. Most of the time, you would still need to do your confirmatory testing to fully understand the whole picture. But if it's in the right patient, right clinical complaints, if this is being done in a clinical setting, then you could do the rest of your HPI exam, clinic, review assistance, et cetera, and say, this is probably a pretty positive. This is a high probability of being a true positive. I'm going to start this person's treatment while I'm waiting for the rest of the test results. That's how I see it being used now. And then the other thing about this test is that how good the test is, number of false positives versus true positives you'll get depends on the rate of syphilis in the population. This is true for all the point of care tests. So if you're in a high prevalence population, most of the time when the test is positive, it's going to be real syphilis. But if you're in a low prevalence population, there's going to be a high risk of false positives. And that's just a math thing that I could get into, but I'm not going to. So I say that to say it's important to use this in the correct setting, and that's going to be your high probability true positive setting. This is a dual point of care test that's HIV plus syphilis testing. Again, antibody testing, you get a 2-for-1. It's about $20 to $30. Pretty good reimbursement rate. Again, cost depends on your supplier. It does come with a micro reader that you have to buy, which is this blue thing that's attached. The benefit of that is you're not squinting at lines to determine if that's positive or negative. It is a little pricey though. So there's that. And then this has different samples that you can use. You can use finger stick, you could use venous whole blood, or you can use plasma. And so this kind of gives you a bunch of different options. One thing, again, a treponemal test, so it can't tell you if this is new syphilis or old syphilis, and would not be appropriate where for patients that you with a previous history of syphilis. And then you still have to do your confirmatory testing as usual, but in the right setting, this really helps you, give you information up front. And then this is a dual HIV test. So there might be some populations where universal screening for HIV might not be appropriate. So that's something to think about in using this test. But if you're already doing HIV and syphilis testing in a setting, this would be a good use. This test does take a little bit longer than traditional HIV point of care tests. So protocols might need to be adjusted to account for that. And then there's an at-home testing kit. So anybody can get this over the counter and do their own finger stick syphilis testing at home. Again, it's a treponemal test. It's not clear. This just came out at the end of last year. So it's not clear how this is going to really be used, if it's going to be used. So we'll have to kind of wait and see how that goes. On the horizon, which would be really awesome to have, is this dual point of care test, which is a syphilis screen and confirm. It's a combined treponemal and non-treponemal test. So you get both tests at one time. Like, this would be awesome. It gives you the answer all at once of whether the patient has syphilis or not, kind of the 2 steps of your algorithm at once. It is being currently used in Europe. And I looked up the price, and I think it's around $20, $25 when I converted from euros to USD. But when it was looked at by the FDA in the US, it didn't meet performance requirements. And so I'm not sure where this is going next, but I really hope this comes to the US, because this would help a lot if you could do both your treponemal and non-treponemal tests all at once. So in summary, rapid tests, pros and cons. I guess I wouldn't really call these cons, just things to consider. One, because they're treponema tests, it's sort of hard to tell if this is new syphilis versus old syphilis, but this is where all your other things are going to come in: clinical evaluation, taking a patient history, an exam, review of systems to kind of see what's the chance that this is new syphilis versus is this something old. Performance depends on the setting, that you're more likely to get false positives in a place where there's not a lot of syphilis. And then you still need an RPR for confirmation. I don't really think this is a con. This is just how we diagnose syphilis. You need 2 tests most of the time. And so that's just there. The pros, it's faster than lab-based tests. We're talking 15 minutes versus hours, or weeks or days in some places. So that's part of deciding which would work for you. And then it gives you additional information right away. If you do your clinical evaluation and you're kind of not sure and you get a positive syphilis test, that gives you just one other thing and new different to be sure about your diagnosis. And then this is a great test to use in non-traditional settings where you can't draw blood, where there's no privacy, and also in some populations where it's hard to draw blood, like people who have a history of injection drug use. This might be a good test to use. So this might be why EDs use it as well. So this slide is just key managements of how to diagnose syphilis. I'm not really going to go through it in detail. The point here is that the point of care test gives you a bit of information and doesn't give you all the information you need to know whether this is active syphilis that needs treatment. You still need to do all these other things to make sure. So in your implementation, having a way to get the patient to clinical evaluation is going to be important. Okay, I think I have about 9 slides left. I know I'm close to my time. So let's talk about implementation. And we're kind of going to go through like who, what, when, where, why, sort of. We've already talked about the why. That's what we spent the last 30-ish minutes talking about. So what populations might benefit? So this is just a list of populations that might benefit. Generally speaking, we're talking about geographic locations where there's high prevalence of syphilis, or care settings where there's high prevalence of syphilis. You're going to hear me say that a lot. And then looking at specific populations of people based on their gender identity and sexual, and then some other factors. So this might be good for cisgender women who are less likely to have prior history of infections. It might be good for heterosexual people in high prevalence settings. That's either geography or care setting locations. It might be good in places where there's limited capacity to follow up. An example is folks who are incarcerated. So our state uses the syphilis health check in jails to do screening, and they can treat folks right away. And that's because in our state, we know that lots of the people who end up having congenital syphilis or syphilis are just as involved in some ways. And so screening in the jails is one way to do that, and they have a low barrier to starting treatment. They will still get the confirmatory testing, check with the state health department to see if a person has history, but if the point of care test is positive, they give at least 1 shot of penicillin and do all the other stuff because folks might not be in the jail for that long. And then for pregnant folks, especially in settings I already talked about, our ED and urgent cares that are doing rapid point of care testing for pregnant people. So that for folks who you don't think are going to follow, haven't started prenatal care, you're not sure what's going to happen, this would be a useful test to do. And again, if in the right setting, in the right clinical picture, you would start treatment right away. For gay and bisexual men who have sex with men, reinfection rates are slightly higher in this population. So this population might benefit. I say might, just because you probably most of the time will need to wait for that RPR, especially if you know they've had previous history or you're not sure. But I wouldn't recommend not doing in this population. Like it would still be helpful. Just something to think about, that your reinfection rates might be high. So you might need to adjust your protocol as you go and implement the test. What settings might be appropriate? I told you, you'd hear me say this a bunch of times. Places with high incidence of syphilis, so that could be geographic, county-based, or that could be location-based. thinking about settings where there are low resources, and settings where there might be barriers to following up results that come in later. So this is emergency rooms, where they're not used to following patients and tracking them down. OB triage, L&D, those are places that you might think about that, doing a point of care test. And then places where patients typically don't return for follow-up care. So substance use disorder treatment sites, harm reduction sites, if they're doing STI testing, this might be a place to do a syphilis point of care test. And then generally speaking, some things to consider whether you're picking of which test to use when. Again, similar things, point of care tests can be used when follow-up is difficult, emergency rooms, OB triage, substance use disorder clinics, outreach, any place where patients don't come back for follow-up care. If there is a population of folks who don't frequently access care, this is especially true for people who are incarcerated or people who are using substances and avoid healthcare because they don't want to be judged. Totally fair. When there's an opportunity for same-day treatment, I would do point of care testing. And then if it's a population with high prevalence of syphilis and you're trying to increase your chances of finding new cases and providing treatment, I would consider lab-based testing. If your lab turnaround time is fast, we have a stat lab in our STI clinic. So point of care test is not going to significantly change anything because I can get a stat RPR in like 20 minutes. 15-minute point of care test does not help me in that case. And so I wouldn't recommend using it in that situation. If a population where reinfection rates are high, right, STI clinic is an example, gay, bisexual, MSM is one example. But again, I would say consider, that just means you might need to change your protocols and how you manage positive test results. But I wouldn't say don't use the point of care test if it might be helpful. And then if you're in a place where follow-up is assured, private OB office, if a patient is admitted to the hospital and L&D is going to be there for 1 to 2 days and your turnaround time for syphilis testing is less than a day, they're going to be there when the results come back. So you can just do your lab-based testing. And this is a table from the National Syphilis Congenital Syphilis Endemic Task Force. The link is there and on the previous slides of just when and where you might consider lab-based with point of care syphilis testing. It's a good resource to have. And it also has a bunch of the implementation considerations that I included here. So what might you need to think about? You need to think about staffing. Who's going to do the test? Who's going to follow up on those results? Who's going to get the patient connected to care if they need that? Training, how do you train folks on who should be tested, how to perform and interpret the tests, what to do if the test is positive, how to talk to patients before they do the test, after they do the test, etc. Collaboration with your local health department is really important. Do you need to find out patients' previous history of syphilis and treatment? Do you need to get them connected to care? Do you need to get partner services for their partners? And then making sure you talk with your state health department about whether or not they want you to report positive syphilis testing results. The answer in a lot of cases is yes. And then do you need a CLIA label in order to do the point of care syphilis testing? This is from a toolkit from the Clinical Training Center, and they have a bunch of these little scripts and workflows. I'll just give you a couple examples. They also have a protocol, which I think is in my resource slides, that you can just put your organization name in. But this is an example of how you might coach your staff to talk about syphilis testing in population. It's really an opt-out approach. And then this is an example of point of care workflow that you could, again, take and modify. And then for managing test results, regardless of what the point of care test results are, you want to offer other STI screening and then offer additional services as appropriate. If the point of care test is negative and you're going to do a confirmatory anyway, you want to tell patients, this is negative, I don't think you have syphilis. We're going to do this other test to make sure. You're going to hear back in 7 days, 3 days, whatever it is. And then what do you do next? If you don't hear from us, call us. If you don't hear from us, that's good news, or whatever it is. And then say, we want you to come back in 3 months, 6 months, etc., depending on the patient. If the test is positive, like I said, this is the beginning of figuring out whether this person has syphilis or not. It's very important to have a process where reflex testing happens. It's important to train staff on how to talk to folks about what the positive result means. And then make sure that there's a system for getting folks evaluated by a clinician to determine whether they have signs and symptoms of syphilis, primary, secondary, or neurosyphilis, do a complete sexual history review system exam. If you're doing syphilis testing in a person who has reproductive capabilities, making sure you're doing a pregnancy test then, and then making sure you have ways to offer same-day treatment. This is my summary. I'm not going to go through it because I'm out of time. I have 5 minutes. And then these are links to protocols that you can plug and play and resources that you can use.